two little piggies. I love that. You just joined, and you joined first. Hi, two little piggies. Hi, Tracy, stylist. How are you? Hi, mdxivi. Hi, Ideology Podcast from London. Hi. I should do my London accent maybe another time. Love from Toronto. Hi, Christina from Toronto. Hi, Maria Cudis. Hi. Thank you, two little piggies. That makes me happy. I love that name. That's so funny. That's so cute. Hi, everybody. It's Thursday. And here we are. I'm so excited as always. Hi from Vegas. Hi, Bobby from Toronto. iStory Media. She said, go ahead. Hi, Kay Valentin from Austria. Crescott. There's my German. Hi, Mario Pique. You're a teacher. Thank you for all the work you do. Teachers, God bless you. We're just talking about all the nurses who work in the NICU unit, making them our yippee of the Sunday paper this Sunday because of all the great work that they do, and all the great work that teachers do. Hi from Coney Island in Brooklyn. Wow. Hi, Serena from France. Hi from Seattle. Home Antique. That sounds like a good furniture line. Love from Santa Barbara. Charcuterie from Margie. I love charcuterie. Do you sell charcuterie in Santa Barbara? My son actually loves charcuterie. Maddie from Long Beach. I had so many great years in Long Beach when I was First Lady of California. We did the big women's conference in Long Beach, California. I loved that. Dominican Republic, love that. I've never been there, but I really want to go there. Have Ed Milet on, Beth. Okay, I will. That's a good idea. Have I never had Ed Milet on? He had me on his show, so you're right. I should do that. Okay, thank you for those suggestions. Any other people you think would be fun for me to talk to in these conversations above the noise? I'd love to hear from you, people that you are listening to, that you find interesting, that rise above, that speak in a language that brings us together from all walks of life. I often say, I'm interested in people from all walks of life, be it political, the art world, the medical world, whose mission is to bring us up, bring us together, and give us valid and honest and factual information and inspire us forward. That's my beat. Those are the people I try to bring to you every week. And today we're going to be talking to a woman that I really like, Dr. Lisa Larkin. She has written for the Sunday paper before. I follow her. She's a women's health expert. She has her own practice, which is really great. She's the CEO of MS Medicine, Ms. Medicine. And her passion is women's health. That's also one of my passions, women's health. So I wanted to have her come on today because next week is World Menopause Day, and we know so little about women's health, and we know even less about menopause. And if you're a guy, this is also really important for you to know because you'll love a woman who's going through it. And I'm trying to reduce the stigma around it, the shame around it, and bring it out into the open and talk about it in an open and positive way so that we can begin to treat it as such. So that's really what we're going to be doing today. We're going to talk to her about, she just went to the North American Menopause Society meeting in Washington. She learned a lot there. She's going to bring us up to date about what that is. Hi, Funky Brewer. You said you wanted a shout out, so you got it. There you go. Multiple sclerosis is a major issue affecting women's health, said somebody there. You're right. Absolutely. So is depression. So are autoimmune diseases. Those are all in my, I'm looking at all of those and I'm trying to focus on all of those. So I wanted to bring her on to talk about that so we could all learn a bit more, understand a bit more, and be a little bit more compassionate. I don't see her there, so maybe she's coming. So maybe she's just not here. She's a doctor, so she may be busy. But hi from Newport, Rhode Island, beautiful place. Yes, talk about thyroid. Yes, so many women have thyroid issues. That's correct. I did too. So I'm also really interested in that subject. I'm interested in the subject of hormones, Alzheimer's disease, always I am. Fibromyalgia, you're saying? Yeah, that's also something that we could be talking about. Today we're going to talk, I think, in advance of World Menopause Day next Tuesday. This interview is going to go up in the Sunday paper as well. But we're going to talk about menopause and your brain on menopause, and just try to take it out of the shadows. I'm so tired of all these women's health issues being in the shadows and nobody wants to talk about them. So I don't see her at all. So I have arthritis. It's not fun. It's turned my life upside down. Wow, I agree with that. Somebody saying that menopause has turned their life upside down. Yep, that's kind of what it does, and that's why we're talking about it. Mosh for the win. Thank you so much also for all your support of Mosh. We sold out. We're trying to get back up. So I really am excited about Mosh. I'm moshing all day long in my house, and I've had such great reaction from all of you about Mosh, so I'm so deeply grateful for that. So once I find Dr. Larkin, we will start talking. Bentley, who's here with me, you can't see him. Why don't you see if you can find Dr. Larkin? Is she there?
Yeah,
You're just trying to find her. So we're trying to find Dr. Larkin. That'll be great when she appears, but maybe, frankly, I could talk about menopause all by myself. But I want to talk to an expert about it because it's such a changing and wide open field, and so many women go through perimenopause and menopause starting in their 40s. Some, have hysterectomies and then are shot into menopause. So many young women know nothing about this. So many women who are actually going through it know nothing about it. So that's why I wanted to talk about it. That's why I wanted to talk to Dr. Larkin about it, who's so well spoken about this issue, who's up to speed about this issue. As I said, just came from the big meeting in Washington where they brought all of those in attendance up to date about what's new, what's cutting edge, what are the new therapies, what is the latest we can learn about hormones and not. So all of those subjects are things that I'm going to try to talk to her about if she shows up. There she is. So there she is. She's not really late. I was just kind of early. But hopefully, there she is. Hi, Dr. Larkin. How are you?
Hi, Maria. I'm well. How are you?
Great, great, great. I'm so happy to be talking with you. I'm so glad you came on here. I've been kind of talking about you before you came. So welcome, welcome, welcome.
Thank you. Thank you.
So I was saying, Dr. Larkin, that your passion is women's health, but today we wanted to focus in advance of World Menopause Day really on the big umbrella of menopause, perimenopause. You just came from the big meeting in Washington.
Yes.
What did you learn there that was new, that was cutting edge, that could help people?
Well, first of all, I would just tell everyone watching that the North American Menopause Society is the place to get evidence-based information for women. So if you're looking for a reliable source about menopause, I encourage you to go to that website, menopause.org. The meeting was terrific, and there were so many takeaways from that. The first thing is really about women and heart disease. So there was a whole half day to really update us on what we understand about risk factors for heart disease in women. And I know that you know that women often present differently with heart disease.
Absolutely.
So there's a whole, heart disease in women is different than in men. But one of the most important things I think that came out of the meeting, and again was really highlighted, is these novel risk factors for heart disease in women, right? So women, when they're young, reproductive age, they have pregnancies, they may have pregnancy-related hypertension or preeclampsia, and then they forget about that for years and years. They raise their kids, they enter midlife, and at menopause, that becomes a very significant historical piece of information for your physician to help you really assess your heart disease risk at midlife, because heart disease risk, for lots of reasons, goes up at midlife, and those early things that are associated, premature menopause or hypertension of pregnancy really correlate with cardiovascular risk after menopause. So that was one really important.
That's really interesting. Yeah. So it's really start knowing your health at an early age so that when you're talking to your doctor at midlife, you're aware, or you could bring them up to date about what you experienced if you got pregnant or what you experienced in your 20s and 30s.
Right. And this is really important for women to be aware, because you probably know, healthcare visits are fast. And I can tell you that when women come to see me and I go back and I ask them about puberty and pregnancy, they're looking at me like, why do you need to know that? I'm 55 years old now. Right. And so again, it's just really important, because depending on where you're getting your care, it may be that historical information gets missed as you enter midlife.
So there was a question just came up here, which I thought was certainly very interesting. What is the age range where women go into perimenopause? Most women that I've spoken to have no idea that they're actually in perimenopause.
Right. So there's no blood test to tell you that you're in perimenopause. That's the first and most important thing to take away. So menopause, by definition, is no menstrual bleeding for 12 months. And so that really is kind of, you're a postmenopausal woman after the fact. The perimenopause tends to start 4 to 6 years before that. Now, the average age of menopause in the United States is 51. And so this means that it can be 44, 43, 46. Women are starting to notice, and they will tell you this, the earliest changes of perimenopause and what they're entering this menopause transition. And what they'll tell you is cycle length changes, bleeding pattern changes. They may notice mood, more PMS symptoms before they get their period. They may notice more breast tenderness. This is all related to declining ovarian function and less good quality of eggs. And so you're not ovulating every cycle, and the ovaries are just starting to age.
Well, Dr. Larkin, what I find most women are also, they've heard about that, but what they don't get told about is the mood changes that they go through, and they don't know, they don't associate or connect the two. So women will say, I can't sleep. Yes. All of a sudden, I'm really moody for the first time. All of a sudden, my life looks bleak. I go into a depression. I feel different about my spouse or my partner. I'm angry. I'm different. And nobody connects that to perimenopause. What is that?
Well, I can tell you that there is a huge connection. So what we know is that the peak times in a woman's life for mood disturbance is puberty, postpartum, and the menopause transition. And what do all of those things have in common? They have instability of hormone levels, right? So for decades, women have this hysteria, they've been labeled hysterical. No one's actually ever really thought about the fact that hormones actually have a huge impact on mood, and that it really does tie in. And I can tell you in practice, I see all the time that women for the first time in the perimenopause or in the menopause transition have their first episode of depression or their first episode of significant anxiety, and they don't correlate it either, and it really gets missed. And so again, one of the things that we do in practice is in the perimenopause, one of the things that can be helpful for mood and for bleeding pattern is oral contraceptives, often to even out those swings in hormones. And it can be very, very helpful in addition to all of the typical antidepressant, anti-anxiety medications that we can use.
So, but there's a whole field now that is not medication related, right?
Yes.
People, are also saying, okay, I'm anxious all of a sudden, I'm depressed. Oh, wow, that I didn't even think that might be perimenopause. It is, what else can I do short of taking anti-anxiety, short of going on SSRIs?
Right. There's absolutely no question that lifestyle is important throughout our life, and nutrition, exercise, sleep, all of those things really play into maintaining your body weight into a happier transition through perimenopause into menopause. But the truth is, and I see this in practice all the time, not everyone can manage all their symptoms with just lifestyle. So what we like to think about in the menopause world is about a third of women have really no symptoms. They kind of transition through perimenopause and menopause, and they don't really understand what all the fuss is about. About a third of women have mild to moderate symptoms, and they can manage a lot of the symptoms with lifestyle and, layering their clothes and a bunch of different things. But then there's about a third of women who really are suffering. And those are the women that I see in practice. And although lifestyle is something that I talk about all the time, and certainly good nutrition and exercise and maintaining your ideal body weight and getting good sleep are critical to having a positive mood. But sometimes it's not enough, and we do really need medication.
I think also what the takeaway from what you just said, which I talk to women about a lot, is that just because you may not be struggling with menopausal symptoms doesn't mean that the woman you're talking to,
Correct.
because it's her, she feels suicidal, her feelings are valid too, because it runs the gamut. Just like you see some women say, I breezed through pregnancy, other women, you know, are bedridden for X amount of months. So it's, I think, first honoring the various feelings that come up for women and the various physical feelings, right?
And it's really, there's really a biologic basis. I mean, you know, now in the era of COVID, we can think, right, not everyone who gets COVID has the same severity of illness and different manifestations of that. So the same thing in menopause, you know, some women we really call are more hormonally sensitive, right? So we'll have more of the mood disturbance, more of the PMS, more of the anxiety and sleep disturbance, more of the hot flashes, while other women seem to really, they don't know what the fuss is about, but they are equally relevant. I mean, those, you know, biology is happening to both of those groups of women.
So the big issue also around menopause, Dr. Larkin, is hormones, right?
Yes.
To take hormones, to not take hormones. So many women are still stuck with the story that came out of the Women's Health Initiative.
Correct.
Don't ever go near them. In the Alzheimer's prevention space, many of the researchers and doctors are talking about the window to go on hormones that is a neuroprotector for the brain, right? And I often find that when I go in to speak to my doctor, from all the doctors that I've worked with in menopause, I mean, in Alzheimer's, I'm telling them stuff they don't actually know. What came out of the last meeting about hormones?
Right.
When to go on hormones, how long to go on hormones, is it good for you or what?
Right. So this is, you are exactly right, continues to be the biggest area of misinformation out there for women. Now, I first want to say that I am a breast cancer survivor, right? So, you know, I understand women who are survivors or who are at risk of breast cancer being fearful of hormones because they have that kind of message drilled into them. Really, what you just said about neuroprotective effect for Alzheimer's is really what we know in the cardiovascular space as well, right? That there is a window of time in a woman's life where really the effects of hormones and estrogen are different than they are early on, right around age 50 when someone's transitioning through menopause versus when someone's 70. And what are the differences between those two individuals? By the time you're 70, you're starting to have vascular aging. You're starting to have cholesterol plaques. Your vessels are stiff. Estrogen has a different effect in a 50-year-old who has healthy vessels compared to a 70-year-old. And what also is kind of forgotten is, and to your point, and I know you're so interested in Alzheimer's research and prevention, is that, you know, when you're going through menopause, you can't just focus on what you're worried about with your breasts. And I talk to women about this all the time because women are fearful of breast cancer, but really cardiovascular risk is really important right then too, right? So we know that if you start hormones early, right around the menopause transition, that the data in terms of cardiovascular risk is reduced and mortality is the mortality percent is decreased, right? So you have better survival. All-cause mortality is reduced. And so it's the same thing. Again, it's this window of opportunity to really take hormones. And again, you have to balance that. And I do this in practice, right, with really making sure that you understand a woman's risk of developing breast cancer, right? So we're really doing more work to identify mutation carriers and those women that have a very high risk. And the discussion becomes a little bit different in those women potentially about hormone therapy. But for the vast majority of women who are symptomatic, who are 50, the benefits of hormones in terms of bone, brain, heart health, and sexual function is huge. And so as a breast cancer survivor, I'm still prescribing a lot of hormones. I think the other big myth, you know, is that, you know, you have to get pellets to get bioidentical hormones. And I see there's a lot of misinformation out there. So there's FDA approved bioidentical hormones. We also know that giving them across the skin as opposed to taking them orally has specific benefits. And what we know is that many women suffer and don't get adequate information or appropriate treatment for menopause. And really, again, the news on hormones is not all bad.
There was just a question there that said, I get terrible migraines from hormones. And migraines can come from menopause, actually.
Yes. Well, so let's talk about that. So migraines often get very severe in the perimenopause. And what we know is that, again, back to hormonally sensitive women, many women, if you really have them track their hormones or their menstrual cycles, will be able to identify that their headaches come the week before or right during their menstrual cycle. In the perimenopause, where periods are irregular and hormones are swinging all over the place, the migraines can be triggered. I mean, we see a big increase in the frequency and severity of migraines in the perimenopause. Now, what I would say to the woman about being, the hormones triggering menopause, my guess is that what she's talking about is when she was put on birth control, that she noticed that her migraines were worse. And that may have been several years ago, and she may not have been given birth controls to run them continuously, right? So now many times we have women run their pills continuously so they don't get any bleeding. And in many women, that's really helpful for migraines, particularly in the perimenopausal period. After menopause, many women's, when hormone levels are low and consistently not low and not fluctuating all over the place, many women's migraines improve. Mine personally have improved dramatically after menopause. But in the menopause space, I would say for menopause symptoms, so if you're having hot flashes and you're a woman now and you're 51 and you're still having migraines and oral contraceptives bothered you, you should also know that menopausal hormone therapy is different and much lower doses. And again, may be very actually beneficial for your migraine. So I would go slowly with excluding hormones and really have a thoughtful conversation with your doctor. The other thing is migraine is a very exciting space right now. There's tons of new medications and new developments, and it's been really exciting science. So that's a whole great thing for migraine sufferers too.
Dr. Levy, you mentioned about women, the kind of opportune moment to be put on hormones. And you said a woman who is put on them maybe in her 50s is different from a woman in her 70s. Yet so many women I talk to who went on hormones, there's all of this competing information about how long to stay on it, whether to get off of it, how do you get off of it. And once again, coming back to researchers in the Alzheimer's prevention space have said to me, stay on them. Do not get off of them. Some doctors will tell you 5 or 6 years. That's not true. We don't know enough, but we think that the best protector against dementia and Alzheimer's is to stay on the hormones. What came out of the meeting in Washington about that?
So you're absolutely correct, which is there is no defined, definitive time when women have to come off hormones. We did years ago kind of talk about this 5-year window because we would see with that specific hormone used in the Women's Health Initiative that at 5 years we would start to see the slight increase in breast cancer risk. And so that's where that came from. But to your point, I absolutely don't stop women at 5 years, and I let them continue with continuing to discuss the benefits versus the risk. And to your point, now we can do lower and lower doses. We can do transdermal. And again, we know a little bit of continuous estrogen goes a long way in terms of bone, brain, and heart health, particularly if you're started early. So there's no definitive time now of when you have to come off. But again, the breast cancer risk, we continue to talk to women about and reassess their risk. I would just really emphasize that, and I have women come in to see me all the time and say, I will never take those hormones because I know they cause breast cancer. And when I take a history from them and I see that they're having 1 or 2 glasses of wine a day and they're not exercising and their weight's up a little bit, I can tell them that the data is very clear that their risk of breast cancer from alcohol is higher than any risk with hormone therapy, that their risk with not exercising and being overweight is higher than hormone therapy. And so for me, I really work hard to address other things at the same time and try to put it in perspective. What I say, and as I said, I'm a breast cancer survivor, I literally look at women and I say, all women are at risk of developing breast cancer. You have breasts. I can never tell you that your risk is 0. What you want to ask your doctor if you're thinking about staying on hormones is what's the incremental increase in risk? And truthfully, it's incredibly small. And I would tell you it's smaller than what's even in the WHI that came out, because we're using lower doses of hormones than we used in that study. So again, I'm very comfortable leaving women on them for years. I will tell you, getting up into the 70s, I'm not as comfortable, or closer to 70, because then we do worry that we've had some vascular aging and the risk of stroke potentially is increased. So I'm talking then about getting women off. But again, to your point about, Alzheimer's and neuroprotective, I don't think the jury is in.
So there's so many questions here that I'm trying to answer them or as quickly they're coming very quickly. Testosterone, women struggling with low libido, testosterone, good. Perimenopause, that obviously affects women's libido. What do you think?
Okay, so this is a really good question, and this is a common question in practice. And let me tell you the real truth about testosterone. First of all, testosterone is important for libido in women. Absolutely. Testosterone levels in women begin to decline at about 35, right? So at menopause, when estrogen drops abruptly, testosterone is already low, but it doesn't continue. It continues to drop, but it doesn't abruptly drop like estrogen.
Right.
Many women come in at that late perimenopause and menopause saying, my libido's terrible. And often what we see is that it really is. It's now the combination of very low estrogen levels and lower testosterone levels that are really leading to decreased libido. What has happened, and there was just an excellent consensus paper that came out from the International Society of the Study of Women's Sexual Health and NAMS on a complete review of the data on testosterone use in perimenopausal and menopausal women. And there is data that it is helpful in therapeutic doses, meaning dosed appropriately for women. What I see in practice all the time is women who are getting testosterone pellets, and the dosing with the pellets is vastly higher than what we're talking about where women should be, right? So I see women all the time coming in after a pellet having testosterone levels above a typical male range. And although initially women will get that first pellet and feel great and run around and tell all their friends that their hot flashes are gone and their libido is great, what I see is the women who have been getting pellets for 2 and 3 years and are starting to have all the side effects related to the pellets. And so again, in the guidance, it really talks about using very dose appropriate for women. Now, the problem with that is,
what is that?
Right, there's no FDA approved testosterone product for women. And so we have to use the male product or compounded testosterone, of which I don't like, but because you can't be 100% certain of the dosing. And so I follow levels to make sure in the patients that I have on testosterone that they're not getting outside of the female range, and it can be helpful. I would also say that there is 2 other medications approved for premenopausal women for low desire: Addy, which is a pill that you take every single day, and Vyleesi, which is an injectable medication that you can use on demand. And both of those have an important role for some women and can be very helpful. So it's not just testosterone.
But that's
for
for
sure.
Perimenopausal women, not postmenopausal.
Yeah, well, it's not FDA approved, although there's data in postmenopausal women, and so it would be considered off-label use. But yes, some clinicians will use both of those medications off-label as well.
I think this is people asking, are we going to, this conversation will go up in the Sunday paper, so you don't have to furiously write everything down, because we're going to post this up because I know we're covering a lot. But what I think is super important for everybody to take note of is we often think of women's health in terms of like a mammogram and a pap smear. And I think what Dr. Larkin is saying is that it's so much bigger. Women's health is changing by the year, by the decade. It's bigger than a mammogram and a pap smear. It involves heart health. It involves cognitive health. It involves hormones. We could talk about hysterectomies. But if you're in your 40s and you're experiencing anxiety for the first time, depression for the first time, these are symptoms of being perimenopausal. And these are things to go in and talk to your doctor. Very often you'll go and talk to your doctor and they won't talk to you about these things, which is why I always advocate a woman's physician or an expert like Dr. Larkin. You can follow her on Instagram. She has a whole where she talks about women's health. But there's so many questions here. Is it good to take? I mean, I can't even keep up with the amount of questions that are coming here. So people are like, should I take testosterone with my hormones? Should I continue testosterone beyond menopause?
Well, so these are all really good questions. And I can tell you that women's sexual health and menopause management, it's really individualized care. And you are correct. I'm on a mission to educate and empower women with tools so that they can advocate for themselves. Because what we know is, many clinicians, primary care providers, I'm an internist, really are not familiar with the data about hormones or about the protective effects of hormones or the benefits of hormones. And they will just say when a woman goes in and they don't want to touch hormones with a 10-foot pole, and just start antidepressants for the anxiety and don't even identify that the menopause transition is really contributing to the mood disturbance. And the sexual dysfunction, we know from all kinds of studies, gets completely ignored. And so women really should have to, or if they're having trouble, really find a clinician that is, NCMP certified. There's a good list on the North American Menopause Society website, right? So that's clinicians who have taken a special interest in women's health to get the certification. But find a doctor who does a lot of menopause, and it can be a gynecologist for sure. It can be a primary care provider who has an internist, who has an interest in it. But there is really a lot of misinformation out there, and we know that women are suffering for sure with all of these things.
Yeah, that's the bottom line. Women's health is in a new space, right? We're just beginning to kind of, hospitals are just beginning to have women's health departments. It enrages me every time I go to the doctor. And this is a big subject of mine in the Sunday paper this week. We're actually working with Kindra to do a couple of pieces on menopause in advance of World Menopause Day to kind of bring this discussion out into the open so women don't feel shame around it, they don't feel confusion around it, and they feel empowered with much of the information that Dr. Larkin is bringing here to you today. We want to keep this conversation going. How long should you take these hormones? She covered that, and you can watch that. We'll put it up in the Sunday paper. We'll put this conversation up in YouTube. She went over that. I think most important, as she stressed today, it's individual. So for some women, it might be longer. For some women, it might be shorter. Once off hormones, can I go back on hormones?
So that's a really interesting question. So it depends on a lot of things, again, individuals. So say that you took hormones from 50 to 54 and you stopped them at 54 and you're now 58 and you're still having symptoms. You're still having hot flashes, your sleep is disrupted, you're having sexual dysfunction. You may now know that you have osteopenia because somebody did a bone density on you now, right? You have lots of things. When I think about, can we put that woman back on hormones? I really go back to assessing her cardiovascular risk. So really we use a calculator called an ASCVD calculator. We look at her blood pressure, whether or not she's smoking. Sometimes I will do what's called a coronary calcium score to assess whether or not she's had vascular aging. So I kind of get a flavor of whether or not hormones may be still beneficial or might be harmful, but I definitely start women back on hormones. So again, the right patient, not everyone, right? So again, it's individualized, but there are definitely women where it's perfectly appropriate to put them back on hormones.
Dr. Larkin, thank you. It's always a pleasure to talk to you. I want to keep this going. Maybe every month we can just check in with what we know that's new, that's current. I've done a whole bunch of this on NBC because so many women think, like mammogram, pap smear, I'm out. And we're learning a lot about heart health. Women are 2/3 of those who get Alzheimer's. I want to really make sure that women go to their doctors empowered about their symptoms, that they're not told they're crazy. Do not think you're crazy. You are not crazy. There is a real reason you feel the way you feel. And don't let anybody tell you that you're hysterical or hormonal or whatever. We need a new language around this, and we need to feel empowered and also beautiful at every age and every decade and vibrant and all of that. So I want to thank you, Dr. Larkin, for your great work here. We're going to keep this going, and I think you answered so many questions. This will be up in the Sunday paper. We'll put this up on YouTube and we'll pin it, and you can go back to here because so many questions keep coming, and she's answered a lot of the thermography. I don't know what that is, but we'll get these questions and then we'll do another one. And we'll go over the Mona Lisa treatment, thermography.
Yes, actually, we should talk about that because I don't know if you saw the big JAMA article that just came out about laser.
No, tell me. I don't know.
That's just came out this week. So this is the first placebo-controlled randomized trial of laser versus sham laser, meaning you put the laser in and you don't actually do the laser treatment. And really, it showed no benefit. Really, no benefit. And so this is the first, and it was published in JAMA, not even in Menopause, because the quality of the data is so good. And so again, this is one of the things I really try to educate women about is just be a smart consumer, because devices and things out there are FDA cleared, and they can get FDA cleared with very little data. Not that they're harmful necessarily, they do get cleared, but you may be buying a lot of treatments that aren't really doing very much. And so you have to really be informed. And this was an important study that just came out, and it's getting a lot of press.
And so that's saying that the Mona Lisa treatment in and of itself, not effective.
Wasn't better than placebo sham treatment. So they would put the probe in and do the treatment. Now, I will tell you, in clinical practice, I have seen what I think are patients having some benefit, but my experience has been that local vaginal estrogen or local vaginal DHEA and moisturizers and lubricants work better than the Mona Lisa. And so a lot of women have spent a lot of money on the Mona Lisa and other lasers in the last several years. And this is the first really important study that shows there's a big placebo effect in the women's sexual health space, right? We know that it's about 30% of women will respond to placebo, right? But the laser didn't seem to have additional benefit. So,
wow. Okay, don't come screaming at us if you've had benefit from Mona Lisa.
No, well, no, you can't. I mean, again, I'm not debating anyone's perfect experience.
Yeah,
I'm reporting the study.
Yeah.
So
that was a question. These questions keep coming, but we'll come back in a week or two, talk about Addie and all these other things that for after menopause. It's a really great subject. I'm glad that she was able to answer so many of your questions. And this is what's great is she just came from the big gathering in Washington, which was multi-days of the North American Menopause Society, which was brought everybody up to date. So this is current, up-to-date, factual, evidence-based, scientific, research-focused. Boom.
Thank you.
Thank you, Dr. Larkin. Get back
Thank you for the opportunity.
Always, always. Consider it an open invite. We'll keep it going.
Great. Thank you so much.
Thank you. Everybody can follow Dr. Larkin. You can go on her own Instagram. I follow her. I find that she does a great job. I learn a lot from her. And I hope everybody learned a lot from this conversation today. So we'll see you soon again. Thank you so much for joining. Bye-bye. Can't turn this off. Okay, I can't turn you off, so I'm going to turn you off this way. Nope, you're still not going off. Okay, there you go.